as I said, I'm a medic by background. I spent over 30 years in the NHS, and I've got a great proportion of that leading services organizations through considerable challenges of transformation and change, which also included some of the ideas around how we meet the needs of patients, families, and populations. As a consultant pediatric nephrologist, I was very struck by something that was really, felt when trying to care for children with disease. I can describe very easily an exact disease that affected two families, two children, but because of the difference in the inequality burdens that each family carried, how we addressed that disease, what we were able to do, and actually fundamentally the clinical outcomes were affected by the burden of inequalities that the families carried, which I thought was extraordinarily striking and something that I've carried with me everywhere I've gone. As my colleagues will know, one of the wants I have is to understand how we got here today. So history for me matters, and I think history matters to tell us something about what is it that has brought us to this challenge of inequalities, and what can we learn from that, and then how do we get out of these traps today? And only sharing us some of the thinking and writing in the space of inequalities, you will know from the mid-1800s, Karl Marx observed the impact of industrialization and mechanization, and then built a view, some call philosophical, about how societies have built deep poverty and inequalities and deprivation. And then he took a view on how you might come out of those traps. In the same century, a few decades later, on a different continent, Henry George looked at the United States or the continent of America and watched exactly that industrialization and mechanization, and saw and was describing an extraordinary development of inequalities that were widening and widening, leaving an increasing proportion of communities and societies destitute, hungry, and sick. And he couldn't really initially work out what this idea of progress was failing to do, which was transforming human lives whilst also damaging human lives. And he came to a very different conclusion about the approach one might take as a society to address this growing idea of inequalities. If you fast forward to 2021, David Graeber and David Wengrove wrote this fantastic book trying to understand the origins of inequalities. And it's a really extraordinary read that takes us over many thousands of years to ideas of today, where they conclude, and I would agree with them, which is, of course, that society and how we organize society is a choice. As a result of those choices, we're dealing with structural inequalities that are, in fact, a consequence of those choices. So we could choose to organize in a way that we eliminate or narrow inequalities, or otherwise we have to deal with what we have today. And then most recently, and I never thought I'd ever say this, I really enjoyed reading a PhD thesis from Glenn Millington, a educationalist actually from Blackpool, who wrote this fantastic thesis on the impact of poverty affecting children and young people in Blackpool, and its context and impact on education and the traps that follow. So if we take these kind of really important, but just some of the ideas of observation and understanding, it's about 250 years. Go to the next slide, Carl. We come to I think a reasonable conclusion that how we organize ourselves is a choice that has consequences, and some of those consequences are that we now accept, in one sense, and live with inequalities that are structural, and from those inequalities comes the idea and the challenge of health inequalities. And I've taken this quote from Henry George, which is before you, which I think is very prescient today, as prescient then as it is today. It's very relevant to today. He wrote this in 1879 in his book, which, by the way, was even in today's terms a huge bestseller, having sold over 5 million copies. He says this: differences in civilization are not due to differences in individuals, but rather to differences in social organization. Progress passes into retrogression as inequality is developed. And he goes on to say that the risk to social stability, civilization, and also to democracies is the idea and the consequences which are inequalities. In other words, if we don't deal with the idea, the consequences are inequalities, then there's risk to society, risk to civilization, and risk to democracies. And if we just look at the world we are in today and the outcomes of the idea of democracies and elections, you can see how 1879 is still relevant in 2024. But what does this really mean in the context of health inequalities then? So we're here to talk about health inequalities. So let's move to the next slide, if we might, Carl. And what also is of note is that we've suddenly apparently become interested in health inequalities, right? When in fact we've had inequalities for over 250 years, developing and getting more and more structurally embedded. And yet suddenly everybody's talking about it. I've been to conferences about inequalities, more and more reports are coming out about inequalities and health inequalities particularly. So why? And I have to assume that it must be the pandemic. The pandemic, in one sense, was a tsunami that affected everybody globally. And as it has washed away and left a remnant, and we still live with it to a degree, we have a revelation in one sense. We understand that it had its greatest impact on those that carried the greatest burden of inequalities. It had the greatest impact on those that actually had the greatest burden of health inequalities. So those that died, those that had the greatest morbidity, those that had the greatest impacts in every sense of the individual, the family, the community, was proportionate to the burden of inequalities that they carried. So this revelation has then activated, I would argue, the NHS in this country to be wanting to do something. And of course, that's not unreasonable. The NHS, because it has health in it as a title, suddenly is asking providers to do something about inequalities. So it has set out initiatives like inclusive recovery. So we're now in a country like other nations carrying a massive burden of growing number of folk wanting care and having to wait longer and longer for it. So now there's an idea of inclusive recovery for which I have great concerns. I'm not going to talk about it here today, but I will certainly be drafting an essay on this where I believe the idea of inclusive recovery, I think about the inequalities to determine how you manage your queue, is quite a challenge to the very foundations of the NHS. But more on that another day. The NHS has set out a 20+5 initiative, which is look at your 20% most deprived population. If we understand what a hospital does in terms of its business model and model of care, it works like this. You walk in, you get referred in, or you're ambulanced in with a disease or a diagnosis that needs to be made. You then get treated, or a treatment plan is set and you're sent out. That's fundamentally what a hospital does. So I'm not clear what a hospital can do that is beyond that, because it can barely cope with what that demand looks like. And that challenge then is what are the skills and capabilities that people are asking for hospitals? And we know that that's challenging because we've done workshops with boards on exactly this question of what is it you think you can do as a provider of healthcare in the context of inequalities. And of course, the NHS rightly thinks about access. You know, the folk with the greatest burden come to disease diagnosis later, have a poor prognosis, and seem to therefore consume more of the resources. But if I just go to this picture at the bottom, which isn't a real picture, it's one of these images colleagues have generated using AI, of course. We walk past people in London, certainly, who live on the streets. And there are people who live on streets in other cities in this country. During the pandemic, we decided we were not going to allow that to happen, and we supported them into better accommodation, safer accommodation. But that's all gone now. So they're all back on the streets. And in one sense, I believe they represent the extreme end of inequality burdens. They represent everything about inequalities and health inequalities. They have visible and hidden health inequalities. They will die earlier, they will have a more terrible life, and yet we choose, and I say that deliberately to be polemic perhaps, we choose to do nothing about people that live on the streets. But we could, but we choose not to. So if I go to the next slide, I don't want to end on a negative note, because fundamentally this is about thinking differently. This is about ideas. This is about what is the evidence that we can use and what is it that health can potentially try and do that is beyond its existing business and model of care approach. So in order to try and narrow inequalities, which seems to be a sort of mantra of the NHS, we must narrow health inequalities. I think we have to ask some really fundamental questions about the idea of the employer, the economic enabler, and the service provider. Do we understand our staff? And part of this webinar, colleagues will touch on the idea of organizations as employers and what it means to think about that particular space. What is it about hospitals and healthcare providers in terms of driving economic impact? And I'm not saying that hospitals now need to employ more and more people. We already have a problem where productivity and efficiency is really very challenging because of that sort of growth in staff numbers that is now challenged by regulators around the efficiency the taxpayer expects. What can we actually do as providers locally rather than just take the national perspective? So there are good questions to ask, and I'm going to end with some of those questions and hope that we'll get many more through the rest of this webinar. So I'd like